You work, you get insurance, you pick an in-network doctor, you show up on time, and you still end up staring at a bill you don't understand, for a price you never agreed to, with a deadline that feels like a threat. This video is a countdown of 15 reasons the US healthcare system keeps doing this to people. You'll learn how the money actually moves, why the rules feel rigged, and what you can do to protect yourself the next time you need care without needing a law degree to survive a doctor visit. Number 15 is the simplest problem and maybe the most shocking. You often can't learn the price before you buy it. In most parts of life, you see a price tag, you decide, and then you pay. In healthcare, you might get the care first, then a bill weeks later, then another bill, then a correction, then a letter from someone you've never met saying you owe more. A big reason is that the price of care is not one price. There's a sticker price that almost nobody pays. Then there are negotiated prices that can change depending on your insurance plan, the network, the location, and even the exact way a service is coded. Two people can get the same test in the same building on the same day and get different bills. That's not a bug. It's how the system is built. Hospitals and clinics can publish price files, but those files can be hard to use, written in code-like terms, and still not tell you what you personally will owe. And even if you get an estimate, it can be just an estimate, which means the final number can still move. That uncertainty doesn't just annoy people, it changes behavior. People delay care because they're scared of the cost. Others overpay because they don't know what to question. And the few who try to shop around often hit the same wall. You can't compare prices if nobody will tell you what the product costs until after you've taken it home. Next is 14, and it's the one that makes a lot of people feel guilty when they shouldn't. Insurance often doesn't feel like insurance. In everyday life, insurance is supposed to protect you from big surprise costs. But in healthcare, many plans come with deductibles, co-pays, co-insurance, and rules that split costs in ways that are hard to predict. You might pay full price until you hit your deductible. Then you might pay a percentage after that. Then you might still owe more if you go out of network. And even when you do everything right, you can still get hit with costs you didn't expect because coverage is full of categories. Some things are covered, but not until you try other things first. Some things are covered only if the doctor uses the right words. Some are covered only at certain locations. Some are covered only if you get them during specific hours, or as an outpatient instead of an inpatient. And here's a quiet twist. A lot of people are insured, but still can't afford to use their insurance. That's called being underinsured. It's not rare. It's what happens when your monthly premium is only part of the real cost, and the rest of the cost shows up when you're already sick, tired, and least able to fight paperwork. Insurance becomes a maze, not a shield. Now number 13, and it explains why the maze is so big. The US healthcare system is loaded with administrative complexity, and that complexity costs real money and time. Think of all the steps. Checking benefits, getting approvals, filing claims, coding visits, appealing denials, correcting errors, sending bills, resending bills, answering calls, negotiating payments, sending to collections, updating records, then doing it all again next month. Every one of those steps requires staff, software, and rules. On the provider side, clinics hire entire teams just to deal with billing and insurance. On the insurance side, there are teams that review claims, manage networks, negotiate contracts, and design rules that control what gets paid and what doesn't. None of this makes you healthier. It's paperwork work, money work, dispute work. And because the rules vary by plan, by employer, by state, by network, by contract, and by year, the system can't settle into something simple. It keeps reinventing itself. A small coding change can change a bill. A small paperwork mistake can trigger a denial. Then you're stuck proving your own reality, like you're arguing with a machine. People assume the healthcare fight is between patients and disease. Often it's patients and process. Number 12 is where that process turns into delay, prior authorization, and step rules. This is the part where an insurance company can say, "We need more information before we'll cover that," even when your doctor already decided you need it. Sometimes this is framed as making sure it's necessary or avoiding waste. And yes, there are cases where review can prevent harm. But in practice, the burden often falls on patients and doctors. Doctors and nurses spend hours filling out forms and making calls. Patients wait. Sometimes people abandon treatment because the delay is exhausting. Sometimes a person gets worse while waiting. And the rules can feel backwards. You might have to try a cheaper medication first, even if your doctor believes it won't work for you, just to earn the right to the one your doctor wanted from the start. Meanwhile, the clock is ticking on your pain, your job, your sleep, your ability to function. The controversy here is simple. In many cases, the people making these coverage decisions never examined you. They didn't watch you try to climb stairs. They didn't see how your symptoms changed. They're looking at a file in a rule book designed to control spending. That doesn't automatically make them evil. It does create an incentive problem. The incentive is to say, not yet, and try again, because delay itself saves money when people give up. Now number 11, and it's the one that turns a stressful day into a financial disaster. Out-of-network landmines. You can pick an in-network hospital and still meet an out-of-network professional inside it. You can be taken by an ambulance you didn't choose. You can get lab work sent to a place you never heard of. You can wake up from surgery and learn that one person in the room didn't take your insurance. Laws have tried to reduce certain surprise bills, especially in emergencies and specific settings. That's a real improvement. But gaps remain, especially with ground ambulances, and the real-life confusion is still there. Even when a bill is legally disputable, you still have to dispute it. You still have to spend time. You still have to understand the difference between what you owe, what you might owe, and what someone is trying to make you pay quickly. The system often counts on the fact that many people will pay just to make the stress stop. And even when you're protected, you might not feel protected because the letter in your mailbox doesn't come with a calm explanation. It comes with a number, a due date, and a tone that suggests you did something wrong. Number 10 is about why this feels personal even when it's structural. Your health coverage is often tied to your job. That's not how most wealthy countries do it. In the US, employer-based insurance became common for historical reasons, including how wages and benefits were treated during and after wartime policies. Over time, it turned into the default for many working adults. The result is job lock. People stay in jobs they'd leave because they're afraid of losing coverage. People delay starting a business because they're afraid of losing coverage. People time life decisions, marriage, divorce, moving, retirement, around insurance. And when someone loses a job, the loss is not just income, it's also access to care, or at least access to affordable care. There are ways to keep coverage temporarily, but it can be expensive, and it's often confusing. And it creates a weird moral story. We treat healthcare like a benefit you earn, instead of something you need because you're human. When care is tied to employment, illness becomes a workplace issue. A cancer diagnosis becomes a career negotiation. That is an exhausting way to run a society. Now number 9. The system is fragmented into different programs and rules that don't fit together cleanly, and people fall through the cracks during life changes. In the US, coverage can come from employers, individual plans, public programs, military-related systems, and other categories. Eligibility can depend on income, disability status, age, family size, state policies, and paperwork. If your income changes, your coverage category might need to change. If you move states, rules might change. If you turn a certain age, you may switch programs. If you become pregnant, categories shift again. If you're caring for an aging parent, you may be dealing with 2 different systems at once. And during these transitions, paperwork matters. Deadlines matter. Forms matter. If you miss a step, you can be uninsured for a period, even if you did nothing wrong other than being busy, stressed, or sick. The system treats coverage like a continuous math problem, but real life is not continuous. People's incomes bounce. Families change. Jobs change. Health changes. The friction in the transitions creates gaps, and gaps create emergencies, and emergencies cost more than steady care. Number 8 is the incentive problem at the center. The US has long paid for a lot of healthcare using fee-for-service. That means providers get paid for each visit, test, procedure, and code. Pay more for doing more, not necessarily for making people healthier. That doesn't mean doctors are greedy. Most clinicians want to help. But incentives shape systems even when individuals have good intentions. If you get paid more for procedures than for long conversations, the system will drift toward procedures. If you get paid for volume, the system will drift toward volume. And when a clinic is under financial pressure, it may schedule shorter visits and higher patient loads. That can lead to rushed care. Rushed care leads to missed details. Missed details lead to repeat visits and extra tests, which the system can bill for. Meanwhile, prevention and coordination, things that keep people out of the hospital, can be harder to fund. You can see the weirdness in everyday moments. A doctor may not be reimbursed for a long, careful phone call, but a facility might be reimbursed well for a certain procedure. The system often pays for the dramatic rescue more than the quiet prevention. Number 7 is where the money concentrates: consolidation. Over the last few decades, many markets have seen hospitals merge, health systems buy clinics, and large groups gain bargaining power. When a region has only one or two dominant hospital systems, those systems can negotiate higher prices. They can also set terms that affect which doctors are in-network. And when insurers face large provider systems, the negotiations can turn into power battles where patients are stuck in the middle. Consolidation can sometimes improve coordination of care. It can also reduce competition, raise prices, and leave patients with fewer choices. Another angle people miss is how this affects local culture. A small, independent clinic might decide care based on community needs. A large system might decide based on corporate strategy. You may notice more facility fees. You may notice more layers of billing. You may notice that scheduling feels like dealing with a call center. That's not always because people stopped caring. It's often because the organization got bigger, and big organizations run on process. Now, number 6, and it's the one everyone argues about: prescription drug pricing. In the US, drug prices can be high for many reasons, and it's not just one villain. There's the cost and risk of research. There are patent rules and market exclusivity periods. There are strategies that can extend the life of a profitable drug through small changes, new versions, or new delivery methods. There's limited competition in some categories. There's also a long chain of middlemen between the manufacturer and the patient. Rebates can flow behind the scenes. Formularies decide which drugs are preferred. Patients can see one price on a list, another price at the pharmacy counter, and a totally different price if they pay cash or use a discount program. That is not normal. The controversy here is that the system can reward high list prices even when nobody wants high list prices, because discounts and rebates can be calculated off the list. So you get a game where the official price rises while the negotiated deals move in the background, and patients who are uninsured or who have certain kinds of cost sharing can get stuck paying closer to that inflated list. People often ask, why can't we just pay what other countries pay? The answer is complicated, but one honest part is this: other countries often use centralized negotiation or price controls, and the US has chosen a more fragmented approach. Fragmented systems struggle to bargain as one group. Fragmentation weakens leverage, and weaker leverage usually means higher prices. Number 5 is about primary care, and it's a quiet crisis. Primary care is the front door to the health system. It's where prevention happens. It's where chronic disease gets managed. It's where early signs get caught before they turn into expensive disasters. But primary care is often undervalued and overbooked. Many people struggle to find a primary care doctor who has appointments soon, especially in certain areas. Visits can feel rushed. Clinicians can burn out. And when the front door is jammed, people go to urgent care or the emergency room for things that should have been handled earlier and cheaper. That's not a moral failure by patients. It's a system design problem. If you make the front door hard to use, people will climb through windows. Another piece: primary care often involves long-term relationships and slow, steady change. That doesn't always fit neatly into billing codes or quick productivity targets. The system is better at paying for events than paying for relationships. But health is built on relationships. Trust, follow-up, consistency. When those are missing, care becomes fragmented, and fragmentation creates repeated tests, repeated stories, repeated mistakes. Number 4 is mental health care, and it shows how a system can promise something on paper but fail in real life. Many plans say they cover mental health. Many laws aim for parity, meaning mental health should be treated like physical health. Yet people still struggle to find therapists and psychiatrists who take their insurance. Wait lists can be long, networks can be thin, the cost can be high, and the paperwork can be intense. There's also stigma, which makes the system's barriers even worse. If you already feel ashamed or exhausted, you're less likely to keep calling office after office after office. In some places, the only available care becomes crisis care. That means people get help only at their worst moment instead of getting steady support earlier. The system ends up paying for breakdowns instead of paying for stability. And because mental health affects sleep, work, relationships, substance use, and physical health, underfunding it spreads harm everywhere. A broken mental health pipeline turns into a broken everything pipeline. Number 3 is medical billing itself, which often feels like its own separate industry. You can receive multiple bills for a single visit because different parts of the care are billed separately. The facility bills one thing, the physician group bills another, the lab bills another, imaging bills another, anesthesia bills another. You might pay at the front desk and still owe later. You might get a bill even when your insurance says the claim is still processing. You might get a bill that says, "This is not a bill," followed by a bill that looks final, followed by another bill that contradicts it. And when bills go unpaid, the consequences can be harsh. Collections can start, stress spikes, people cut other spending. Some people skip future care to avoid more bills, which can lead to worse illness and bigger bills later. There have been efforts to reduce how medical debt shows up in consumer credit reporting, and some institutions offer financial assistance policies, but patients often don't learn about help until they're already in trouble. The system is backward. It often makes you prove you can't pay only after it's already punished you for not paying. Number 2 is the way healthcare interacts with everyday life factors that medicine alone can't fix. A huge share of health outcomes depends on things like housing stability, food access, safe neighborhoods, clean air, time for rest, ability to exercise, stress levels, and steady income. Doctors can prescribe medicine, but they can't prescribe affordable rent. They can advise healthy eating, but they can't make groceries cheaper. They can recommend sleep, but they can't give you fewer night shifts. The U.S. system spends a lot on clinical care, but it often underinvests in the conditions that create health in the first place. This creates a loop. People get sick because life is hard. Then healthcare gets expensive because people are sick. Then people go into debt. Then life gets harder. Then health gets worse. It's not that clinicians don't understand this. Many do. The problem is that the payment systems and policy choices don't consistently reward the work of prevention in the real world. The system is built to respond after harm happens, not to keep harm from happening. And now, number 1, the reason all the other reasons keep surviving. Accountability is scattered, and the people who feel the pain are rarely the people who can fix the rules. Patients don't usually choose the full terms of their insurance. Employers choose plans, government sets rules, insurers design networks, providers set charges and codes, drug companies set list prices, middlemen negotiate deals, regulators oversee pieces, not always the whole. Everyone can point to someone else and say, "That part isn't mine." When a bill is wrong, the patient becomes the project manager, calling 3 different offices that don't share the same information. When records don't transfer, the patient becomes the courier. When a denial happens, the patient becomes the lawyer. When someone is sick, they are least able to do this work. Yet the system often demands the most work at the worst time. That is the core failure. A system that requires expert-level navigation from people in crisis is not a system designed around health. It's a system designed around transactions. If you want to turn this into something useful, here's the question I want you to answer in the comments. Which part of this system feels the most unfair to you? Prices you can't see? Rules that delay care? Or the way bills show up after the fact? And if you've learned any trick for avoiding a surprise bill or fighting a denial, share it so someone else can use it. If this video helped you understand what's going on, hit like, send it to one person who's confused by healthcare bills, and subscribe for more videos about how everyday systems really work.